Hi, everyone. Good afternoon. Thank you for having me. So today I'm going to give a talk on AI in healthcare. I'm going to give a brief overview of what has happened in the last 20 years. This talk will be relatively short, and I'm going to try to introduce my research into this perspective of AI in the last 20 years. So a couple of more things about me. I'm the director of the IMEX Lab, Intelligent Model Computing and Sensing Laboratory. And my research interest, as you can tell, is in AI, machine learning, more specifically with applications to smart health and progressive health, as we call it. So brief overview of our presentation today. I'm going to start by explaining what happened in AI 20 years ago. Then we're going to make a stop to a little bit more recently, 10 years ago, present day, and then some predictions for the future that I think where I think we're going. So first of all, let's start with the definition of AI, so we're all on the same page. We're talking about artificial intelligence. We're talking about systems that can perform tasks that require some type of intelligence, similar to human intelligence, okay? But AI has different branches. What has propelled AI in the last few years and has made it so popular is a branch of AI called machine learning, which is the ability of computers to learn directly from data, as opposed to humans providing knowledge to computers and encoding their knowledge. So let's start with that. Let's see what AI looked like 20 years ago. So in about roughly 2005, we had what we call expert systems. Those systems basically try to encode human knowledge into a set of if-then rules, make decisions to support clinical decisions, and so on. Now, this knowledge was manually encoded, right? So as you can tell, those systems were not very robust, they were brittle, and it's almost impossible to be able to encode the entire human knowledge that a doctor or a clinician or a nurse holds in their head in those systems. So a good example, still AI systems existed back in 2005. In fact, computer edit detection for radiology was first approved in 1998, if my sources are correct, and it started getting used in the first few years of the 2000s. And those systems acted as kind of a second pair of eyes. So the doctor would look at the X-ray, but then they would have this system either flag some parts where the doctor should maybe pay attention more, or just like confirm as a second pair of eyes. And they helped increase the detection rates. They were useful, but they were not transformative. Their goal was not to come up with new patterns or new knowledge that maybe the doctor had not noticed. It was just to make sure that there was consistency, basically, when the knowledge that the doctors have is consistent across different subjects, different patients, reduce mistakes, and so on. Okay, but there was a big problem with these systems, as you can imagine. First of all, encoding human knowledge into a program is a difficult task. It's very hard for people to express all the things they know into text and rules. Second, as you probably know, healthcare and the knowledge constantly evolves, and these systems were very rigid. Once you had created it, it's very hard to add new knowledge and incorporate what these systems already knew. So that was a problem. That's why they were not widely used. Now, if we fast forward 10 years and come to 2015, we see the boom of deep learning. In fact, it started in 2012 with a paper that introduced a new neural network called AlexNet that was able to perform much better in image classification than previous traditional machine learning systems. So the core idea of deep learning is that instead of encoding human knowledge and what we call also human engineering, we just give data, we give labels, and we let the system figure out the rest. It will figure out what kind of features are important for classification. It will figure out how to combine them in a certain way, and it can even come up with things that humans maybe did not know that they were important. Okay. Also, these systems were enabled by the fact that our data increased by a lot. We started using electronic health records in hospitals that could be fed into such systems. We had digital imaging that can be used directly for computers. And last but not least, more powerful GPUs, because the computational cost of training such systems is really, really high. And it was only made possible when we started being able to train them in graphical processing units as opposed to regular CPU clusters. Okay. Now, let's say the poster child of one of the breakthroughs in deep learning was medical imaging. And a particular application was automated screening for diabetic retinopathy. Okay. So the idea there is that, the retina people that suffer diabetes has some issues that ophthalmologists were able to manually see in the past, but you could train systems to automatically detect such problems. And actually, unlike previous models, they could even do better than experts in some cases. Okay, so these systems learn the relevant features from raw pixels. That's a big difference. But this shift from rule-based methods to data-driven methods created some new problems. And those were the need for data. These methods are very data-hungry. And the trust crisis. These methods, they became so complex that these days it's hard to tell why such a system makes a decision. So we have what we call the black box problem. It can tell you that this person has this disease, but it can classify them to different categories, but it's very hard to tell why. Okay. So there's research going on in that direction, and part of that research is also in my lab, which I'm going to explain in a minute. So coming to today, where are we standing? So AI can provide benefits, and it can augment humans in many different ways in terms of healthcare. One is a physical type of augmentation, where we can collect data using wearables and then sensors and so on, and basically monitor health in real time. And then the other one is the cognitive augmentation, and you already know the ChatGPT and other chatbots, where those things can be used by the patients as end users. They can be used also by experts. We all use them in our daily lives, but they can even be used for other more research-oriented tasks, like drug discoveries and so on. So let's see a few applications. I'm going to start with continuous monitoring and wearable sensors, which is a big thing these days. You probably have heard about Apple smartwatch and so on that can monitor your sleep, but also other types of similar devices. And an example, it's a classical example, and my lab has done extensive work in sleep monitoring in the past. Somebody had to go to a sleep lab, spend the night, get wired with dozens of sensors, and it wasn't very convenient. But the biggest problem is that after that, an expert would have to review all this data with some assistance, with some of these systems, the CAT system that we mentioned, that could do some automatic flagging of things, but the final responsibility lies in the expert. And there was a lot of data to review. So a lot of our work has been how to kind of make these systems less obtrusive and move from the lab into home. And these days there are actually commercial products that can do a good job of sleep monitoring, and data gets collected, gets sent to the cloud, and so on. But there is still a core challenge here, which is these data are not, clinical grade. They are consumer products, noisy. So how do you integrate all these different data from different sensors? How do you clean them up? And how do you get reliable clinical insights? Still remains an open problem. So the bedrock of building trust in modern AI systems could be broken down into three main areas, which is data integrity. Is how do we ensure that the data that we collect is accurate, reliable, labeled correctly so we can train these systems reliably. Explainability is another issue. How do we solve the black box problem so that if there is some kind of a decision that AI gives you, can you trust it? Why do you come to this decision? And then finally, data scarcity is a big problem. As I mentioned earlier, deep learning systems are very data hungry, and all AI these days is based on deep learning. So if we can have plenty of that, we can collect, but when we're talking about medical data, as you all know, there are privacy concerns there, labels need to be assigned by experts and so on. So there's not as much as we have for training the general GPTs. So my lab has worked on all three of these areas, and I'm going to give you a couple of examples of our contribution in the next few slides. So one of them was ensuring data integrity. So we developed a semi-automatic labeling system where the users can label just a few things, a few of the data initially, some seed labeling. Then the AI labels more data, but target asks the user for certain when there is a particular instance where AI is uncertain to provide feedback, the more important one. Then we have another system, THR, we call it for time series and labeling, where AI can detect potentially incorrect labels and flag them for human review. Another example that has to do with explainable AI is a system that we built that provides temporal attention signatures to experts. What do we mean by that? One particular data set that we worked on was heart disorders. And there are a few different heart disorders that can be detected by the abnormalities in the ECG signal. But when an AI tells you that this person suffers from this disorder, if the AI analyzes the signal, do you trust it? How do you make the decision? And can the doctor kind of get something out of it, some insight about this data? So what we did is, besides just providing the decision, we create a heat map of the signal, as you can see here. The orange line here is the ECG signal at the time, but what you can see here is for different types of disorders, which parts of the signal, this heat map shows us which parts of the signal does AI consider as important for making the decision. So that's just one example on explainability. The other problem that we tried to kind of mitigate was data scarcity. As you know, in health, first of all, we have lack of data in general, but there are even worse, some cases, some diseases, some disorders that appear very rarely. So you might have a lot of data from healthy people, but very few instances of that particular disorder. So this AI seems to struggle a lot when you have class imbalance, as we call it. So our contribution was to develop, to use generative AI to create synthetic data instances that can be used to train models and kind of mitigate this class imbalance to a certain degree. Okay, so now all the things that we're working on, they're not just to improve the models, but they are a necessity. They're becoming a necessity because a lot of regulatory bodies now they are requiring certain, let's say, properties from the AI systems. Like AI systems should be able to be transparent and explain their decisions when they make critical decisions. They should allow human oversight. Humans should be in the loop, and there's a robust data governance need, data integrity, and so on. So all these things that we work on kind of cover some of these things. So let's move on to the future and try to look ahead and think, okay, what will AI in healthcare look in the next few years? So my personal view is that AI is going to become more personalized. It's going to move from preventative to from reactive to preventative, sorry. And it's going to be more adaptive to the individual person as opposed to just one size fits all approach that we've had so far. And this kind of elaborates more on the one size fits all approach that healthcare used to have in the past. And that was understandable because we do not have data from individual people, their everyday sensors and so on. So doctors have to make decisions based on what they knew in aggregate as opposed to individual. But that could change with AI because we have the sensors to collect the data and we have the computational power to analyze each person's data individually. Okay? Another thing that has happened, as you all know recently, is large language models, and they've had a lot of impact. You might have heard that they're currently even being used for drug discovery. They're combining large language models with solutions to new research problems, new drugs, and so on. But also in our everyday life, they can be used for support of patients, for support of experts, and so on. One thing that I want to point out is the danger for over-reliance in AI. As you already know, AI can make mistakes still. I actually saw a meme recently on Twitter where somebody asked AI if those mushrooms are safe, or I don't know if they're very safe to eat, and the AI said, yes, go ahead, they are great for gut fella. Then 1 hour later, person said, I'm in the emergency room, those were poisonous. And the AI said, oh, you're absolutely right. Do you want to hear about 10 other poisonous berries? So that's what happens with AI these days. So it's not fully reliable yet, and we have to be careful when we make decisions. So just a couple more slides, a couple of predictions for the next few years. So I think these digital signatures that we're creating from each individual eventually will probably lead to something like human digital twins, where doctors have like a full digital simulation of each patient, and they can use that to predict possible future outcomes. We will, let's say, test possible medicine and how that person will react to that particular medicine. And that comes back to the personalized health that I mentioned before. The other thing is hyper-personalized closed-loop care. So this is some more of my work that my lab has done, which had to do with virtual reality interventions. We've been collecting physiological markers from veterans suffering from social anxiety and PTSD. We developed a VR lab. Our goal so far has been to be able to detect in real time increased stress levels. But you can imagine the next steps of this is that as this happens in real time, the system can automatically adapt the intensity of the stimulus so that it's still the intervention is effective but not overwhelming to the person. So it's going to be like a closed loop care that involves. So what's left? What are the remaining barriers for full AI adoption in healthcare? Well, first of all, we need to ensure that we have, AIs are free of bias. Algorithmic and data bias is an important issue these days. And they're also equitable, that everybody has access to this type of healthcare, not only people that can afford. Privacy is a big concern, because as we get more and more of our data digitized, this digital twin that I mentioned, we need ironclad privacy, because at that point, it's not just that somebody can steal your information and know things about you. They can actually physically hurt you. They can hack into your digital twin, and I can tell the doctor that this person needs this medicine or something like that. And so you can imagine things like that. Accountability is another important thing. AI will make mistakes, as we saw. So when that happens, who's accountable? Is it the company that makes the AI? Is it the doctor that uses the AI? Is it just the patient's responsibility? And so on. And finally, we want to always augment humans and not replace them, obviously. So, and especially in health, this personal connection is very important, as you all probably know. So we can't just replace doctors and therapists with AI completely. We can try to augment them and help do their job, make their job easier. So what's the strategy for achieving all that? My opinion is interdisciplinary collaboration is very important. So we can just have AI experts develop systems that think they're useful and then just hand them over to health experts. They need to be part of the development process from the beginning. And I believe we also need some kind of co-evolution. So computer scientists need to understand a few things about healthcare, so we need to educate ourselves. And I think that's where AI can actually help. I can ask chatbots today to tell me a few things about healthcare that I don't know. And the same thing, I guess, applies to health professionals, where maybe they can try to understand a little bit about the limitations of artificial intelligence, and best use cases, what to be careful about. So in conclusion, and I'm sorry, I think it took longer than as I was planning to, but we saw a brief overview of the AI journey in the last 20 years. It has moved from expert systems that were very brittle and not very widely deployed to pervasive AI, where, as we know, AI is everywhere today, not just in health, but in our smartphones, in YouTube, and everywhere it's used. So it's not just something that computer science researchers do these days. Everybody needs to know about AI. It's becoming the new, I don't know, basic education, I would say. So that concludes my talk. I'd like to thank you all. I would love to have some time for discussion, but I think we have another talk with Dr. Wright, so we can reserve that for the end if we have more time.
Thank you. I know you have a million questions, because I do too. We're going to have time for questions at the end, if that's okay. I just want to make sure that we have time for our second speaker to do her talk. Dr. Allison Ihle is from UT San Antonio, and now he will talk.
Thank you. I just wanted to get you up. Thank you. And I'm gonna intend it. I'll 40 or a little bit before that. So that was a really nice introduction by Dr. Metsis, because a lot of what he talked about, I'll sort of also elaborate on how we translated that into an intervention and use nursing science with computers, engineering and science to make this intervention. So I'm going to talk about the methodological approach to developing a mobile health intervention that we call JUNE to help manage care amongst women within the criminal legal system. The funding that supported this work was internal funding by the Clinical and Translational Research Pilot Grant Award from the Institute for Integration of Medicine and Science. And then it was also supported by the NICHQ. And I just have to say that the content is solely the responsibility of the authors and doesn't reflect the views of NIH. And so just a little bit of background about this phenomenon, if you're not familiar with the criminal legal system in women's healthcare or women's health issues. So the past 50 to 60 years or so, the amount of childbearing women, so women between the ages of 18 to 50, has significantly increased, and our criminal legal spaces about 900% of an increase within the United States. And this is from a lot of the war on drug policies back in the 70s that created harsh penalties for very low-lying offenses having to do with poverty. And so a lot of these people are first-time offenders, very low-level crimes, caregivers to young children under the age of 10, and pregnant birthing and parenting. And so right now, we're trying, there's been efforts, especially within the last maybe 15 to 20 years, to reduce this. But criminal legal spaces were not initially designed for people that are reproducing. They were designed for men, right? And not families and young children. And so, and people that reproduce. And so, what we've been seeing is that a lot of these people, because they're first-time offenders, they are prioritized for what's called community supervision or probation, which is a form of community-based legal oversight where they are followed by a probation officer, but they are still under the umbrella of the criminal legal system. And although that community supervision is less restrictive than prison or jail, right? And people think, oh, it's so much better. They actually are hit with a lot of socioeconomic barriers because they are expected, especially here in Texas, I've learned, I've been collaborating with other states like Minnesota. I just assumed everybody had the same stipulations for probation, but I was not. Texas, very punitive. So within Texas, most of these women have felonies for these low-level offenses. They get out and they're required to get a job within a month. If they don't find a job, and so many of them are pregnant and many of them have felonies and then have barriers like transportation, childcare. So if they don't get a job within a month, they get rearrested. There's also restitution. So it costs money to be on probation, anywhere at minimum $60 a month up to a few $100s. And so they have to also pay not only for that covers their court costs and probation officer salary and everything, but also weekly drug tests. All of this costs money. They can't take their children to go report. They have meetings, they have classes that take time during the week. And so to balance that with caregiving, with a job that they're supposed to have, many of these people recidivate, or that's a fancy word for getting rearrested. And so we have a huge volume of women in this age group in Texas specifically that are in this category. I didn't realize that, like, so just in Bexar County, there's 21,500 people on community supervision, about 5,400 a month. 5,400 a month are pregnant and parenting. So that just gives you sort of like a snapshot compared to Minnesota. The people I work with over there, when I told them those numbers, they're like, we have like 600 a month total, men and women. So if that gives you a perspective of how much we incarcerate people here in Texas compared to other states, it's a huge problem. And then when you think about the socioeconomic effects, right, of these caregivers circling in and out while they're reproducing, and the trauma that's carried on across to their children and family, it's a huge health equity and economic thing here, especially in Texas. So a lot of my work has focused on criminal. This is during COVID, and you know, knowing that most of them are on community supervision, I focused a lot of my work on that space. And what I've learned is that women's health issues are not being studied or evaluated in these spaces. There's very little research in jail and prison spaces around women's health, but even more so within community supervision. They're just not even really acknowledged. This group getting initially arrested already has high adverse childhood experiences, which is a term that we use a lot in research in social sciences, just meaning that across about 10 different domains of neglect, physical abuse, emotional abuse, they've experienced quite a lot by the time they become an adult. And they say, literature says 4 or more ACEs out of 10 is a predictor of being, you know, eventually into the criminal legal system, and many of them do have at least 4 ACEs. They once admitted, you know, their first arrest, they already have high morbidity and mortality, and that's just sort of it gets more pronounced after they come out because of the trauma just associated with incarceration, but then some of the trauma when they get out. So I learned early on that there was an urgency to create tailored interventions that addresses their dynamic lives and needs. And so I'm going to talk about sort of the transition from my early work. And so this is a framework called the Information Systems Research Framework. And so it's a framework that I've used to sort of guide the design from the beginning, which is the relevance cycle, which consists of interviews, reviews of the literature, all the preliminary studies that I did, and then the design cycle, a lot of what took place after that in collaboration, not only with research participants, but Office of Commercialization Innovation and some of the collaborators that I have now scaling the app for me, and then the rigor cycle. And that's the cycle that we're in right now, in which we are doing some pilot tests and some validity and reliability testing with the chatbot. So I wish, well, let me talk about the first. So some of the preliminary studies, and they go from the most recent to my first one. So my dissertation study was a qualitative study. It was during COVID. I interviewed 12 women. At the time, I thought that because I couldn't go into the jail systems, I thought that would be a barrier to participation or getting data. So I recruited from the jail annex as they were coming out, and probation and different recovery homes. I learned quickly that, because we always learn in research, you want to be in person with the person and interview them. But actually with this group, me being on camera without video feature, they were actually a lot more responsive, and our interviews on average lasted 2 hours, some up to 3 hours. And a lot of them said, you know, I've never had anybody ask me about my experience. And so I had a lot of data, a lot of papers were produced from that data, but collectively there was a lot of trauma, stigma, a lot of socioeconomic barriers to healthcare and limited healthcare. So they either didn't have access. If they did have access to healthcare, they couldn't get healthcare because of transportation or child. If they did access healthcare because of their lifestyles, people were just awful to them. They did say because of technology during COVID, a lot of interactions, whether it be with their counselors or probation officers through Zoom, actually helped them not only feel more safe because you had that extra layer of confidentiality. And talking to me about the video feature, there was a lot of things shared that I think I wouldn't have gotten had I been face to face. But also they said they were able to not only access resources, but also complete the requirements of their probation better because of the electronic. They didn't have to worry about childcare or transportation, which was two big things that hindered and got in the way of completing the requirements of probation. So I got my postdoc at UT Austin, and I learned on, I did a lot of, my mentor was in precision health methods that uses pretty much big data sets and technology and wearable devices to understand human behavior. And so what Dr. Metsis was talking about digital phenotyping, we learned a lot about that. And that's just pretty much somebody's digital footprint and how they interact with their wearable devices. So like as a healthcare provider and a consumer of healthcare, I'm pretty sure all of you could agree. When you go engage with healthcare, I'm notorious for this because they ask me, what's your symptoms? And I can't think past a week, I forget. And then I leave and I'm like, oh, I forgot to mention, you know. And so what's interesting about having a digital phenotype, meaning a footprint of different time points of interaction that this person's having with their wearable device, is that we are able to get a more comprehensive picture of their daily experiences at the intersection of their health symptoms, maybe where they're living, social determinants, things like that, because we're getting a much more, you know, I guess, sophisticated picture and more data across time instead of cross-sectional retrospective data when they're sitting in front of you in the doctor's office, right? So I did some scoping reviews in my postdoc and early on, and so we just looked at perinatal outcomes in criminal supervision or community supervision cases. Out of 14 plus 100 articles retrieved, only 4 looked at perinatal outcomes, and they're mostly around mood disorder and substance, like perinatal substance. Nothing around like preterm birth or, you know, like all the other stuff that nurses and healthcare providers probably want to know. And then I did a review of the literature looking at mobile health that's specific to community supervision spaces. Just very broadly looking, there was 231 articles, 5 median inclusion. But then criminal, or, you know, community supervision spaces, and only 1 that looked at women. None of AI. Then we looked at, I did a study that was funded by the NIH. We sampled 60 women from community supervision in San Antonio back in 24, and this is interesting. I had data saturation within 48 hours. My phone was blowing up. And that just tells you, again, these people want to participate and they do want to engage and get better healthcare, and there's a huge need. But yeah, I was shocked at the response of that. But we measured, that was off of an RO1 that was doing enhanced perinatal programming within 8 different states and prison systems. I had a supplement off that RO1. I took their same measures and applied it to community supervision just to see what their outcomes and needs are. Unfortunately, I was only able to get cross-sectional data, so I had to ask people what their experiences were with pregnancy, childbirth, and postpartum while in community supervision. And got that data, and we're now analyzing it. We have 3 manuscripts right now under review. I think I posted them here on that data. And then from there, early on as a faculty member, I did an intervention development study where I used pilot funding to sample 11 women on community supervision. We tested 2 apps that were already on the market for college women around sexual health behavior and partner violence, intimate partner violence. And from there, they told me what they liked and disliked about those apps and what other features they wanted to see in an app that would be particularly for them. And then we did one last review recently that looked at community supervision engagement. So engaging with those departments to address health issues. Out of about 482 articles, only 11 met inclusion, and only 1 addressed gender-specific issues specific to childbearing women. But again, nothing really pregnancy, childbirth related, more around just like substance use in pregnancy or things like that. So essentially, there's a big gap. I wish I had brought slides of the app, and usually I would take you maybe to the site to show you the app, but all of that work informed what we know today as the June app, and I wish I could, if we have time to pictures of it, but June is short for the Junonia shell. So I spent like 6 months trying to figure out it, and I was like, you need something that's like discrete, but also representative of the sample, and we were going back and forth and asking participants, and people were like agave, lotus, all these things, and I'm like, no, and June, I did a search for shells native to Texas. Junonia shell popped up. It's native to South Texas. I liked it because it means strength and self-sufficiency and courage, just like the participants. And it's orange, like orange speckles. So I'm like representative of UT Regents for the research. I'm like, we're gonna name it June. And so we named it June. And then from preliminary data, we incorporated what the participants liked from the sexual health behavior app was that they were able to track their sexual health behavior with their partners. And I had them engage with this app for a month. And one of the findings from that pilot study was that they said, I've never had time for a tool to manage my own health. I take care of my kids, but my own health, I've never been able to track it. But having a tool that gave them statistics and their trends over time, like it asked them, did you wear a condom? Did you have shared decision-making? Like just things like that. It gave them a way to track their behavior over time to see patterns, and gave them sort of like a platform and validated some of their experiences to start conversations to change behavior with their partner. And so they liked the statistics feature and the journal feature. And so we adopted that. But those two apps didn't have AI ability. And I knew I wanted AI within the app. And so our app has, it's built around an AI chatbot that we call June. So you're talking to June. And so it has that. And then it has a library feature where nursing students and I spent a lot of time writing and editing the content specific to their needs, and making it trauma informed and very much tailored to the needs of this population when it comes to substance use and personal honest chat room. So the study that I'm about to talk about right now, that was something that participants this past year shared that they would like to interact anonymously with users. So we have incorporated that recently, haven't tested it yet, but we do have that. We have what I'm really excited about is it's called a journal feature, but it's actually, I call it symptom tracker. We didn't name it as that because we wanted it to be discreet, but it's essentially an AI-led triage feature where we have different domains. So like substance use, relational health, general health, reproductive health, mood, list it all. And they could click whatever categories they want to check their health. It gives them a list of signs from normal to abnormal and critical. And then as they put it in, we train the bot on the back side. I used like nursing rationale. So like if I was your triage nurse and you were to call and say, I've been bleeding, I wouldn't automatically say you need to go to the hospital. I would say, when did it start? What color? What's the amount? And so depending on what they put into the back end, we have it on a scale from 0, not critical, all the way to 10 critical. The bot will say, this sounds like it could be critical. You might want to go to the nearest hospital. Or this is abnormal, but not critical. You should keep monitoring. And so we've made it very clear throughout this whole process. I worked really closely with our IRB legal and IT team. Also, I was talking to Reddy and Robert today, very closely, most recently with our Department of Innovation and Commercialization. But we made disclaimers on the app, and when we're consenting people, we say, this app doesn't diagnose, nor take the place of healthcare, but it's help to just help with decision making, right? So we make that very clear to people. But we have that feature, and then we have a resource feature, a resource tab where right now it's static. We're working on integrating AI in that. So if somebody's having a conversation with the bot and or in the symptom tracker, it could say, oh, wait a minute, you need this resource, and route them to that resource instead of it being like a list of resources that we have to update over time, because that takes a lot of manpower and updating. So we got funding a year ago in collaboration with the computer science team. So the prototype for June was in combination with UTSA, their computer science department. We were able to get funding where their computer science student worked under me in collaboration with their department and with some folks from San Francisco that has now taken over the production of the app. And so we've recently, our last participant is going to end the study this Friday, but we recruited essentially 50 pregnant women, 25 on probation, 25 off, during pregnancy to see how they interact with the bot and to see if their health behavior is different between groups. And so that's some of the measures that we had. And so essentially we just want to see if self-efficacy during pregnancy is different. What are their experiences? And is their interaction with the app different? So on the back end, we're looking at frequency and time of use. And then we're also asking if the bot tells them you should go get healthcare, we have a follow-up question a few hours later asking them, did you go? And if you didn't, why didn't you go? Was it because of X, Y, and Z? To measure self-efficacy, so we have a health efficacy scale that we gave at the beginning of the intervention. Then we told them log into the intervention daily for 3 months, and then we gave the whole scale at the end. During the 3 months, we set up the bot to where it had role-based prompting with a shortened self-efficacy scale. So like the first month, they would ask every participant at, the time frequency, how well on a scale from 0 to 4 have you managed your stress? And depending on how they rate themselves and the timing and just sort of their behavior interacting with the app, then the bot on month 2 and 3 will tailor its response to those that need it more. So those with low self-efficacy, the app nudges them more. Those with higher self-efficacy, it sort of backs off. This is the interface of the bot. And so that's sort of what the screen looks like. And so this just sort of talks about the inclusion. So these are preliminary results that we got in September. So we still had a couple of cohorts, like I said, like my last cohort ends this Friday. So just looking at both groups, these are the significant or trending for significant results in the community supervision or probation group. So when we looked at some of their results, that group had more housing instability. They were worried about food. They needed money for food. They were worried about their electricity being shut off, and they needed help with resources. Other things that were trending towards significance that I think now, after we get all the data after this week, probably is significant, is that the probation group had more newborns with health complications, past complications in childbirth, complications with recurrent pregnancy, anxiety, and not being able to stand up for their rights effectively. Usability, and this reflected some of my preliminary studies. A lot of the women in the pilot study said they used the app at night in the comfort of their home. Same thing here, a lot of their usability data reflected that. Mondays and Wednesdays are popular days for the app use. And then down to like the digital phenotyping and the what Dr. Metsis had shared, the way we trained the bot on the backside was around different, I wish I had a picture of this, but the content that we put in the backside, we put labels around different emotions, but also categories and challenges. And so we were able to see just by their interaction with the app, some of their feelings in that group compared to the other group. And so I'm going to breeze through this, but this is just some of the results from the interview. They didn't, for the most part, have access to preventative care. A lot of the times these were unplanned, barriers again, socioeconomic barriers. And it's not on the App Store yet because we're still piloting it. That would be helpful. And then an anonymous chat room, and we have put anonymous chat room in. So real fast, I'll fly through this. These are the labels that we set the algorithm up. So like just what Dr. Metsis was saying, the bot needs some classification. It sort of knows where to siphon its decision making. And so all of these categories are from different preliminary studies. And so me and my team made up of students, took preliminary data and some stories that were told over time. Also, I told them write your own stuff too, because we're all different, right? But we wrote 100 sentences for each domain to train the bot. So around all of those different colored categories, we wrote 100 sentences in natural language. These are some more of the domains. And so then from there, we trained the bot. And then, and because like Dr. Metsis was saying, initially the bot, when I first got the architecture from the company from San Francisco, if somebody were to put in my dad died, the bot would automatically be like, I'm so sorry your dad died, you know, which would be sometimes a normal response. But in my population, sometimes death is celebrated because the person that died was their abuser, right? So we don't want it to, like, we want it to be more sensitive to different, you know, or like, I'm on methadone, like trauma-informed care, that's okay, right? But initially the bot would be, you know, judgmental about that, maybe on during pregnancy. So we had to train it. We trained it and then we retrained it using another 120 sentences. So before we retrained it, I had a student interview the bot. So we created an interview guide with sentences from each of these domains. And this is what the interview guide was. So I told her, interview the bot. I want you to ask one sentence, wait till it responds. Ask the other sentence, wait till it responds. Ask another sentence, wait. And then at the end, before moving to the next one, put never mind. So the bot would reboot itself. So she did that first time after training one. That's sort of what the interview guide looks like. And so you could see where Crystal, the student, asked it a sentence and then June replied. So that's the transcript we got from the backside. And then we retrained the bot and we re-interviewed it. So now what we're doing is, and I've yet to do it, but we're doing it now, is that we put it into Deduce, which is a qualitative software to analyze and we're gonna do a comparison analysis between the pre and post interview to see if June got smarter and what type of feedback it was giving. And so that's the model, the usability model that we're using to code the qualitative data. You can see the codes here. And we're gonna see if June actually was efficient, made a mistake, had a suggestion, and what does that look like. So that's what we're working on right now. The engineers did some validity testing, sort of like what Dr. Metsis had talked about. You know, we're working with a vulnerable group. Some of them have mood disorder or substance use, a lot of like complex things. And so essentially what this means is that there was no false positives when the model predicts crisis. It was always correct. So we have trigger words that it picks up. One of which, like one thing that it automatically notifies me for is if somebody says they have plans to harm oneself or somebody else. That's automatically routed to me, and I have a protocol in the IRB for me to follow up with it. There's other things that, you know, I can't respond to every crisis, like bleeding and stuff, you know, but when they did it, it picked up on every crisis. For things that weren't a crisis, it had lower precision but perfect recall. So it catches all non-crisis cases, but had some false positives. And so we'd rather it be a little bit overly sensitive and make a mistake that it wasn't a crisis than miss the crisis altogether. So far it's picked up on crises pretty well, with overall 92% accuracy and performance. And pretty next steps is to try to generalize our sampling and do more validity testing and also testing on making it more culturally sensitive and appropriate for different groups.